The following Cardio-Oncology Spotlight was recorded at the American College of Cardiology meeting 2025. The meeting title was Advancing the Cardiovascular Care of the Oncology Patient. And there we had a chance to sit down with some of our colleagues who were speaking at the meeting about their individual sessions. We know you're going to enjoy these short but meaningful segments. Thanks for joining us. This is Steve Caselli. I'm at the American College of Cardiology meeting in Washington, D.C., the Cardio-Oncology meeting. And I'm joined here with the president of ICOS, Dr. Susan Dent. And we are here with a friend and colleague, Dr. Eric Chow, who is at Fred Hutch out in Seattle. Works primarily in pediatrics, but does a lot of work in cancer survivorship. So we're chatting with him today about survivorship.
Great. Thank you, Stephen. So at this conference, you're going to be speaking about survivorship, particularly as it pertains to survivors of childhood malignancies. Perhaps we could just start out by asking you, what are some of the key cardiovascular risk factors faced by adult survivors of childhood cancer?
Sure. Thank you so much for introducing the kind introduction, and very happy to be at the Heart House for at least a second or maybe third time. Mm-hmm. And thanks to all the great work that ICOS does in advancing this particular field. I mean, I think for childhood cancer survivors, I think the standard conventional, cardiometabolic risk factors remain important. I think what's unique maybe a little bit about this population is, whether you believe in the concept of premature aging or accelerated aging, what we do tend to see is these patients do present earlier in life with some of the standard cardiovascular risk factors compared with the general population. And so having greater awareness of screening for these things and what might otherwise appear to be young adults, I think is probably the key intervention that can get missed. So if you have a 20 or 30-year-old who otherwise is not obese, they may still have hypertension or dyslipidemia, in part worsened by their prior treatment, and either not recognizing that or not intervening on it has been associated, at least in observational studies, to increase their risk of future, more serious heart disease.
So just perhaps building upon that, what are some of the late sort of cardiovascular events or that you see in survivors of childhood cancers, recognizing that it's a different population than the adults. Hopefully they're healthy, and then they develop cancer. We give them certain treatments, whether it be radiation, immunotherapy and chemotherapy. 10, 15, 20 years down the road, what are these survivors facing in terms of cardiovascular risk?
Yeah, I mean, the major treatment-related risk factors, still are going to be chest or cranial radiation, right, causing valvular damage, premature atherosclerosis or increased risk of stroke. Anthracyclines, which remain commonly used in probably at least half of children's regimens. That's well known to be a risk factor for treatment-related cardiomyopathy. I think the challenges for both of these is the latency on which these conditions present. So rarely, in 5 or 10 years when these patients are still children, but for the most part, these are people developing, early, myocardial infarcts or cardiomyopathy, clinical cardiomyopathy, in their 30s or 40s, still at a very young age, but much sooner than, people in the general population.
So building upon that, if we know that those individuals are at risk, and it can be, 10, 20 years out, when they're essentially young adults, what kind of best practices or guidelines do we have to help us, monitor these individuals and hopefully try and prevent some of the longer term complications of the cancer therapies they received?
Yeah, the pediatric cancer community has developed pretty detailed guidelines, maybe overly detailed. They're quite extensive, but they're also hard to find, hard to read sometimes. And I think the biggest challenge is probably that divide between pediatric and adult care. in that adult clinicians aren't always aware of the issues that are specific to pediatric patients that are now adults, like whether it's survivors of cancer or other kind of chronic conditions that begin in childhood, whether it's cystic fibrosis or congenital heart disease, or even like type 1 diabetes, right? There's a challenge in transitioning those patients from pediatric to adult care. I think cancer survivors are no different, where things get dropped. Sometimes it's familial or patient-based reasons. Other times it's just lack of familiarity of adult providers with some of the specific recommendations that are germane to that kind of fairly unique population that tends not to make up a large proportion of the adult primary care providers practice, or the adult cardiologist practice.
So just building upon that, at this conference, we've heard a little bit about how you build a cardio-oncology service. Now, that focus has generally been on cardio-oncology services for adults who develop cancer. How do you think we can improve upon that to incorporate some of these individuals who are transitioning, from pediatric to the adult world? Because I think, as you mentioned, they can get lost in that transition. Should we be looking at the cardio-oncology services and having them as a subset or a patient population that we bring in to those clinics so that we can continue to monitor them and hopefully prevent some of the devastating cardiovascular disease that may occur? Just a thought.
Yeah. No, I think cardio-oncology is a specialized enough field where I think the cardiologists that are engaged in this do appreciate childhood cancer survivors, at least in my experience.
Mm-hmm.
And so I think probably the key thing is, on our part as a pediatrician, we try our best to educate the patients and their parents, because it's usually the parents who are oftentimes still reminding those young adults, by the way, have you gotten checked the last 5 years? That just because we have to say graduate them from the pediatric institution doesn't mean everything's done. And as best we can, try to instill in them a message that because of their treatment, they still need ongoing follow-up for specific things, i.e., screening for cardiomyopathy, more aggressive attention to modifiable risk, cardiovascular risk factors. And we try to provide clear instructions to their primary providers about that risk. And I think more and more we're trying to provide services for adult age survivors of childhood cancer so that they can continue to get that information. And for us as a provider in that survivorship field, being able to communicate those recommendations to their adult providers so that the patient themselves are not the ones having to advocate for themselves, which can be challenging in some situations.
Again, I think you're right. It's that communication, but also the challenge of making sure that as they get into adulthood. And again, also, I think you assume that, some of these young adults want to get on with their life and they're not thinking necessarily about prevention of cardiovascular disease when you're 20 or 24. But as we know, they're at risk. They're definitely at a risk population. What advancements sort of in research or clinical care do you see in this area? Either something that's happened recently, or where do you think the field is going, or how can we advance the field in terms of improving upon the outcomes for these individuals? I mean, I remember seeing data looking at the sibling match studies showing that the siblings do so much better, obviously, who are not exposed to those therapies. And so there's a lot of research that's been done in this area. What do you see happening in the next 5 years that's going to sort of improve upon what's been done previously to hopefully improve clinical outcomes?
Yeah, I think, a lot of the research has been observational, and I think there is some signal that in more recent eras, the gap between, say, siblings and their siblings who have not had cancer versus, their family members with cancer has narrowed, but there's still a very large difference between those two groups. Obviously, pediatric oncology, like medical oncology, has benefited from a lot of new drugs introduced in the last few years. This past decade has been really amazing. Some of those are now in the process of maybe replacing or reducing the use of both anthracyclines and radiation. Now, whether that actually translates into better long-term health, I think remains to be seen, because we think that they have a better side effect profile, but the long-term side effects, still remain a little bit unclear, especially with some of these, immunomodulating drugs, which they could potentially have long-term immune-related issues, which may not manifest for decades potentially. But I think the other gap that we're trying to fill in now is, while still doing these observational studies, trying to do more interventional studies to provide improved evidence base for what interventions may be helpful. Some of these are in the kind of care delivery space, where can we test counseling via nurse practitioner, or even nurse-led, or even lay health educator-led interventions to improve both survivor and provider knowledge of their risk factors, and thereby improve screening or control of these risk factors, both for cardiovascular disease as well as second cancer screening. There's been a large body, or not large, but there's been several randomized controlled trial results that have come out over the last few years, or are coming out over the next couple years, focused on these topics, for example.
There's been a lot of attention, at least in the adult oncology space, looking at lifestyle modification. And so we're seeing now studies coming out looking at the role of exercise, diet, management, of course, of cardiovascular risk factors. But you see, moving forward in those who've survived a childhood cancer, looking at those type of strategies prospectively to see if you can instill some of these lifestyle, factors to promote, hopefully, a long healthy cardiovascular lifestyle.
Yeah, I don't know if that's a leading question, I guess.
It is, because I just think that, we focus in a sense, but we tend to focus so much on drugs and, putting patients on medication. But I do still think that there's a lot that we can do with regards to just instilling in, whether they be, survivors of childhood cancers or adult survivors, just some very lifestyle modifications that could make huge differences. And I would argue maybe even some that are similar to the drug interventions that we try.
Yeah. The reason I said maybe it was a leading question is, we recently completed a randomized controlled trial, which we call CHIP, that was more about improving screening and control of modifiable risk factors by improving coordination with primary care providers. We're hoping to submit that paper soon. Did show some improvement, albeit both in the intervention as well as in the control group. It was presented at ASCO last year, which showed that maybe just earlier screening and release of these results, like your blood pressure was this, your cholesterol levels were this, your diabetes screen show this results, giving that information back to primary care and the providers, or primary care providers and the survivors themselves. These were all adult age survivors of childhood cancer in their 40s. Actually showed about 25-30% improvement, was just giving back the results. And it wasn't any different than the intervention group, which was the results plus a personalized survivorship care plan.
Which I think is amazing, because if you had a drug trial that showed a 30% improvement, everyone would be excited.
Right.
Yeah, so, I just think it's obviously not that simple, but I think that as we look at, new and exciting drugs coming on, into this arena, such as the SGLT2 inhibitors, certainly in the adult population, we can't forget that, there are other things that we can do in addition to adding in drugs that may benefit individuals.
Yeah, and obviously, and I think, those drugs would probably, the effect of those drugs would be enhanced by concurrent, lifestyle change as well, if that can be both implemented and sustained. So we do have a follow-up trial called SALSA, which, as a joke, actually, but we made the acronyms work. So it's not just cardiologists, but I guess oncologists are known to have good acronyms as well for their studies. But anyways, this follow-up study is called SALSA, and it's focused on improving diet and physical activity in survivors of childhood cancer who are adults, testing a variety of different strategies, ranging from more of a clinical model with advanced practice providers providing some counseling. There's an M Health group, and then there's a randomization halfway through, and then there's a health coach that gets involved, who's a person with kind of both nutrition and exercise training expertise. So that trial is underway. It's about 3/4 done with enrolling. We're hoping to get about 400 randomized patients. And so hopefully we can show whether one of these strategies is more effective than the other, and whether the sequence of introducing these different styles of interventions, all with kind of goal setting in mind, but delivered by different people or modalities, if that also makes a difference, because sometimes people may be receptive to one way of absorbing this information than others.
Yeah, and I mean, I can say as an oncologist, we're not necessarily good at doing that.
Yeah.
We're not the best people necessarily, because we're so focused on the treatment and the side effects and getting people through their therapy. When you start talking or introducing lifestyle interventions, we may not be the best, individuals to discuss that with patients. So, just sort of one last comment. When you think of this whole evolving subspecialty of cardio-oncology, about 85% of the involvement is from cardiologists, and about 15% involvement from oncologists in terms of who we see coming to meetings, including membership and ICOS. What are some of the strategies, or have you thought about how you could get more of your colleagues interested in this area? Because I think, and it's a hard question, I know, but I think oncologists have traditionally shied away from this whole concept of bringing these two disciplines together and looking at how we can, improve our ability to give cancer therapies that can have cardiovascular complications.
I don't know if I have a great answer for this one. That's, I would say, oncologists, myself being one, we tend to look at, shorter term oncology outcomes, right? And at least in children, these cardiovascular outcomes don't tend to occur in the 5-year window that we're so focused on. I will say, I think NIH, or NCI has been more interested in looking at longer term outcomes. So some of the, at least pediatric Hodgkin's trials, they've felt that, just looking at 5-year event-free survival is no longer sufficient, and that they really want the Children's Oncology Group, for example, to focus on trying to establish mechanisms to look at 10, 15, 20-year outcomes, knowing that, we have very good cure rates for Hodgkin's at the 5-year mark, but Hodgkin's historically have one of the worst survivals if you plot out their long-term survival in terms of 20 or 30-year outcomes, mainly because of premature cardiovascular disease or early breast cancer, things like that. And so I do think having, in the 20 years I've been doing oncology, I guess, there's much greater awareness of survivorship, long-term survivorship issues than there was when I started. And so even if that hasn't necessarily translated to greater involvement or membership in, things like ICOS, I think people are much more aware and realize the importance of not just focused on that 5-year oncology outcome, but that there's a more holistic
I think that's
that
an important point, because I even, as a breast cancer oncologist, I have patients in my practice who think if they get to the 5-year mark, they're home free. And they're not. Obviously, they're at risk of recurrence of breast cancer basically for the rest of their lives, but also they're at increased risk of some of the treatments that I've given them in terms of cardiovascular health. So I think I agree with you that I think there is much more focus on survivorship now than there was even a few years ago when I started practicing. And I think there is a good interface between survivorship and cardio-oncology, because survivorship really begins from the time you're diagnosed with cancer, as a new definition, defined by ASCO. And so it really is looking at both together. So hopefully with some of these interventional studies where you're looking at lifestyle intervention, and by looking at longer term outcomes, from interventional therapy for childhood cancers, we'll even see more of that down the road. So any last words in terms of your session survivorship, or that you'd like to share with us today?
No, I'm just very appreciative of American College of Cardiology doing these type of workshops, and I think spreading the news, even if it's not getting a lot of oncologists involved. If oncologists, we're very ready to refer to cardiologists if something's amiss. So if the cardiologist on the other end of the phone or consult line is much more familiar with these issues, then we're all going to be in a better space for our patients.
Yeah, and maybe I'll end by saying, I think as oncologists, those individuals will never benefit from a cardio-oncology referral unless we refer them. So I think it's just the awareness of, these are the patients who are at risk, and we should be referring them more proactively than reactively, because as at least in the adult world, we have tended to wait till patients get into trouble with cardiovascular disease and then we refer them. And I think the whole shift, and really what we're trying to emphasize, is that if someone's at high risk at the beginning of their cancer therapy, get cardiology involved early. It will mean hopefully that patient can get the treatment that they need, and you're not going to have, cardiovascular toxicity down the road. So really aligns with what you do in the pediatric population. So thank you very much for joining us today, and for giving us some advice around survivorship in pediatric cancer survivors.
For more information about ICOS, you can go to ic-os.org, where you'll find more information about all of our programs, including our weekly webinars, our board certification exam, and other resources that we know you'll find helpful. Thanks for joining us today, and we hope to hear from you soon.